Before we started to record the meeting, is there anybody new to the PACIO community would like to go off mute and introduce yourself? I don't see. All right. Let's just jump on to our agenda. Um, let's start the recording. Welcome everyone to the PACIO weekly meeting. Today is Wednesday, March 19th, 2025. Today we have lots to cover on our agenda. First, we'll ask Dave to provide the leadership update, and we will switch the order of the agenda a little bit. And we ask Uba to provide the PACIO upcoming conference because the communication pause and the travel pause and affect the CMS and the MITRE team to attend the upcoming conference. But we have a great community. We ask the PACIO community to step up and help with conference submission and attending the conference and present on behalf of PACIO. Uba will talk about the conference coming up, the due dates in March and April. After that, we'll ask our subgroup lead to provide subgroup updates. In addition, the PACIO team will talk about the PACIO USCDI V6 draft comments, and we'll talk about the PACIO strategy to handling the USCDI V6, the leveling strategy, and we'll cover part of the comments, the PACIO USCDI V6 comments. Without further ado, I will pass it to Dave to provide the leadership update.
Great, thanks, Yolanda. Let me get that started. All right, thank you everybody for joining. This is the leadership update. On the communication pause, there's really not been a lot of change over the past week or two. I think HL7's posture is pretty much the same. They seem to be, although, at least, some things are seeming to go through now, which is good. And the PACIO communication pause, there's really no change. We're ready, basically capable of doing everything almost we were able to do before, with the exception of traveling. And thank you very much, everybody, for the folks that have stepped in to represent PACIO at some of the conferences that we've been attending. So many thanks to you folks. So here's the latest use cases and timelines. Standardized medication profile is, all the work has been done on our part. It's still it is not yet published, but it's basically all the work that we've needed to do is done, and we've gotten all the approvals and everything. So it's just a matter of getting that through. And I think HL7's been under a bit of a crunch there. So that's all ready to go. We are continuing to work towards the September ballot on advanced directives, SDU2. And then also we are looking to go to ballot in the May cycle for transitions of care, and we'll talk a little bit more about that later on. And then personal functioning engagement, we're looking to wrap that up, and we've now really completed our reconciliation at this point and are looking to go into publication. So we're starting that process. So I think good progress in all fronts. So on the ADI updates, so as I've talked about in the past, there were some deferred tickets from STU1. There were things that we really didn't want to, didn't have to address at that time, and so we put them as consideration for future use. We've gone through all those now and addressed those. We're also have finished going through all of the ADI consent profile issues and really working towards aligning the FHIR and the CDA IGs. Lisa Nelson's been very instrumental in helping out with that since she's very much involved in the CDA side of things. And then, really determining the appropriate terminologies to be used there. So that's a good thing to be able to wrap up. We're also working on remaining issues from the portable medical order environmental scan. There are a number of forms used throughout the country, and so there are a lot of nuances on those forms. And we want to make sure that we're able to, coalesce those and be able to represent all those things in our specification. So we are still targeting September 2025 ballot for the STU2 review, and we're actively working towards that. Um, any questions on ADI or the other or the timelines? All right. So standardized medication profile, we've pretty much, we finished up the STU1. We've done everything we need to do for publication. We're just waiting for the actual publication to occur. But in the meantime, we're actively looking towards the next release. And so during that January Connectathon, there were some things that came up, things that we could not so much issues with the spec with the actual fire resources, but more or less addition. I think we could use additional guidance in places because there was some confusion on behalf of the participants, and so we wanted to kind of shore those up. So that's one of the things that we want to do. And then, also examine whether there's any new functionality that we want to provide or need to provide. Um, as you may or may not know, this particular work has been largely funded by NCPDP and Pfizer, and that funding went through towards to the goal of publishing STU1. And so that funding is now stopped. So the question will then be, how do we continue to move this forward? And so we're in conversations with Jeff Rochon about that, who's now taking over that use case for Shelley Spiro, who has gotten a well-deserved retirement. So that's kind of the update on standardized medication profile. Any questions on that? All right. So we did attend a couple of conferences this past couple of weeks. HIMSS in Las Vegas. We didn't actually, the leadership really in PACIO weren't able to attend that, but there were a number of other community members who did. Does anybody want to bring up anything about um, what happened at HIMSS? Was anybody there on the call? All right. Well, I understand that there were many mentions of the PACIO project in various settings at HIMSS. We didn't present or anything, but the project was mentioned, and that was great to hear. So we'll it's good to be known and to be mentioned. So at such a large venue. And we also went to the National Academy of Practice annual meeting in Washington, D.C. to talk about the future is now enabling greater post-acute care interoperability. That was March 13th to 15th. And it's again, a great opportunity to reach out to people who may not be interested, or may not be aware of what we're doing in standards and all of that. Is there anybody here that went to that could comment on it?
Dave, I was there. Yolanda, should I just run with it at this point? Because Yolanda had asked me about just recapping next week, but
Oh, okay.
that's okay. Just if you want it now, I can do that. It's just very briefly.
Yeah,
Our,
that'd be good.
our poster was very well received. And it was the busiest poster session I've ever experienced, quite honestly. Lots of very thoughtful questions. Lots of people keeping in mind National Academies of Practice represents 17 different healthcare professions. So you have respiratory therapists and physicians and nurses and dietitians and physical therapists, occupational therapists, speech therapists. So you have quite an array of professionals. And the questions that were raised, we were amazed at the number of people who had absolutely no idea that when they do electronic documentation in whatever venue they service, that they just assumed that information flowed where it was supposed to go and had absolutely no idea that it may not be captured or may not be completely captured. So that was an interesting enlightenment for all of us because these are people who are using these systems all day, every day in their practices. So we had a number of questions, we had some challenges, but as a result of that, we actually had the privilege of having the new president of the American Speech Language Hearing Association visit us and speak with us at great length and has asked us to be involved in another piece of ASHA impact under her new administration. So things have gone very well and it was very well received. And we talked this morning about the possibility of submitting something for this year's convention in November.
Awesome. That's great. Thank you.
You're welcome.
Yeah, that's super news. Any questions? Well, again, thank you very much to, members of the community for stepping in and helping to lead, really help, continuing to lead the charge at these conferences. Very much appreciated. We've got another conference coming up March 28th, the American Nursing Informatics Association in New Orleans, and also virtual. And then we also have had a poster accepted for the AMIA 2025 Clinical Informatics Summit. That's in Anaheim, California on May 20th to 22nd. And then the American Health Information Management Association annual conference in Minneapolis. We've submitted an abstract for that. That's in October 12th to 14th, 2025. So and there's some others that potentially might be in the works as well. So I'll update you those when we have something more to talk about, but when we have something submitted. So, continuing to try to get the word out. And that's pretty much it for the leadership update. Any questions? All right, I will hand it back to you, Londa.
All right, thank you very much, Dave. There was a lot going on, so let's move on and continue talking about the conferences. And I will pass it to Uba to present their upcoming conference. And we are hoping the community member can continue to lead and participate and present.
Thank you, Yolanda, and thank you, Dave, for giving a little bit of a preview. Just as to reiterate what Yolanda said earlier, there's a number of conferences that we've identified where PACIO could contribute, but because of travel restrictions for CMS and MITRE, to help make sure that there will be somebody able to attend the conference, we're looking for our PACIO community members to participate in the submission process, to be co-authors and to be able to travel to the conference. We unfortunately won't be able to provide the registration and travel costs, but we are here, and me specifically, to help with the whole submission process, including putting a proposal together, and if it's accepted, putting slides or a poster together, whatever is needed. So over the next slides, there's some potential opportunities with calls for proposals that are due in the next 2 months. You can either drop in the chat information or your information if you're interested in being a co-author on the submission, or you can send me an email. I'll put my email in the chat in case you'd like to get in touch with me directly. Okay, and also these slides have been posted on Confluence, so if you want more information, you can go there. So the first one that has a deadline coming up in less than 10 days is the American Public Health Association meeting in Washington, D.C. This is a conference for public health professionals, and they have options for oral poster presentations. Because PACIO hasn't participated in APHA before, this opportunity, but would be one where we could talk to them about PACIO overall and give a short demonstration about data sharing across different systems. And there's a link here that if you want more information about the conference, I will drop it in the chat. The next one is the Home and Community-Based Services Conference in August in Baltimore. Deadline is end of March. They allow presentations, and this is a venue for policymakers, leaders who administer, manage, and deliver waiver and other HCBS programs. We haven't presented here either, so this could be a get to know PACIO presentation, especially highlighting how it could support HCBS services. I'll drop the link in the chat here if you want to learn more. The next conference is the ASHA convention, and the deadline here is April 3rd. They have various different sessions available, including virtual opportunities, and many of the participants are also virtual attendees. PACIO has presented before at ASHA, so there's a potential for doing a demonstration of data sharing across systems. And earlier today in the PFE, Personal Functioning and Engagement weekly meeting, we discussed some potential options with some of the PFE community members who are already planning on going. So if this is something you're interested as well, you can let me know because we're actively pursuing this one. The next one is the College for Health Information Management Executives Fall Forum, November in San Antonio, deadline April 9th. These are for digital health leaders, including high-level management. We have not presented to this audience before, so this could be a get to know PACIO tailored specifically for healthcare and health IT executives, demonstrating the technical capabilities of PACIO and potentially also the PAC app. There's a track on interoperability, so this that could be another option there. Next one is the American Physical Therapy Association Combined Sections meeting, February in Anaheim. They have an April 15th deadline for educational pre-conference sessions, but for presentations and posters, their deadline is later in July. This is for physical therapists, educators, students, industry professionals, and because we haven't presented here before, again, do a get to know PACIO with a focus on how to support physical therapy through data exchange and PAC settings. The next one is Behavioral Health Tech Conference, November in San Diego, deadlines April 18th. They have presentation, submission option available. This has a variety of different attendees, including health plans, employers, behavioral health providers, digital health companies, investors, and policymakers. And this could be an opportunity to explain and also demonstrate what PACIO can do, highlighting technical capabilities again. And then this one here is the SNOMED CT Expo. It's in Belgium, but it's hybrid, so there are virtual options for presenting and attending. They have an oral online presentation or an e-poster. Deadline is April 24th. It's a relatively small conference, but this is a great opportunity to reach terminology SMEs from around the world. And this could be an opportunity to demonstrate and describe how PACIO leverages SNOMED and other terminologies to support interoperability. So those are all the deadlines that are for March and April. Just as kind of a heads up, we don't have specific dates for these conferences, but it's very likely that in June, the Gerontological Society of America will have their conference submission due in June. In July, it's likely to have that there will be calls for proposals for the American Psychiatric Nurses Association, Academy Health Conference on Social Term Science of Dissemination Implementation, National Council for Prescription Drug Programs, and as I mentioned earlier, American Physical Therapy Association platform and poster submissions. And then early September, there's the American Association for Post-acute care nursing conferences. So these are just some of a big active list of conference opportunities coming up this year. And I also have in the list ones that have deadlines in fall. So please send me any calls for submissions that you receive that you think PACIO might be interested in. And also, if there's any of these conferences that I went through that you are interested in collaborating on for a submission, please email me and we can talk about how we can make that happen. So that's it for me, and pass it off to Yolanda.
Yeah, I
Thank
just
you.
wanted to make wanted to make a quick comment. I mean, these conferences really feed into a lot of the stuff that we do, because not only do they get the word out and what we're doing for folks, and a lot of them may not be aware of what we're doing, but it also allows them to get interested and participate. And the more the merrier, the more expertise we can bring into this community, the better. And then plus also that it might unleash some piloting opportunities as well, or additional participants at connectathons. And so all of those things are really beneficial for PACIO. So these conferences I think are important to get our word out.
Yeah, absolutely. Thank you very much, Uba and Dave. I think Jamar, you also shared the PACIO poster was accepted in the AOTA Inspire annual conference next
That
month.
is correct. So that's next month. Myself, Alyssa Ford, and Clarice Grody are going to be presenting a poster session. It's titled "Burn the Fax Machine," and standardizing communication using fire. So yeah, we're excited about that.
My apologies for not including it. Sorry about
Yeah,
that.
that is fine. That's
Yeah,
completely fine.
yeah, and that's super.
Yeah, wonderful news. Congratulations.
Yeah, absolutely. We're hoping it's going to drive a lot of engagement. There was a talk last year about interoperability and the some of the work that we're doing in PACIO, and it drove a lot of engagement in our conversations that matter, which are more informal conversations, and that was led by Clarice and Jessica Sopak. I believe I'm pronouncing her last name correctly, who was formerly at MITRE, so we wanted to continue that.
Yeah, Skopak. Yeah, you're right. All right. Great. All great news. And let's move up to our next items on the agenda will be subgroup updates. And Jamar, I will invite you to provide us PFE subgroup updates.
Okay. So, just wanted to give a quick report out to everyone. We had a great meeting today and really good discussions around behavioral health. And we know that behavioral health is being addressed in other areas, but we really looked at what behavioral health data elements that we need in the PFE group, so personal functioning and engagement outside of transition. So, yeah, we had a really good discussion about different assessments that we might use, things that we might look for in the medical record. Again, this is outside of the transitions of care, and as well as strategies, like how do we could we capture strategies? How could those be captured in documentation or from a data standpoint? So. That's what we did in our meeting this morning. Next meeting, we will continue to discuss behavioral health as well as continuing the conversation around ordering equipment to see what we're going to tackle in the STU3. And that is it for me.
Any questions from the group? Thank you. very much,
Mhm.
Jamar.
Absolutely.
All right. Next up is our TOC IG, and lots going on the TOC IG development side. And I will invite James and Terry to provide any updates.
Harry, did you want to go ahead first?
Nope, it's all yours, James. Thank you.
Okay. So we've been working to get ready for the ballot coming up. So we are actively going through and finalizing all of the details in the IG itself. We've gotten the final inputs from our different clinicians and role groups. So we've been able to include the behavioral health community within the Dell reconciliation that is going into the IG. And we've also been cleaning up all the narrative that surrounds all of the different parts of the IG. So we've made all of our milestones so far for finalizing that. And we are going to go through the last couple gates this week and next to get into the final approval for balloting. So that's all in hand. I think we have our content freeze and all of our content is done for today, and we'll be meeting with the patient care work group tomorrow for the first of those last three milestones. I think that's about it for right now. Just all full steam ahead to getting our IG finalized and into ballot. Back to you, Landis.
Yeah, thank you. Dave, are we supposed to vote on the IG?
Yeah, so what I'd like to do is kind of go through through the IG quickly. So this is the main page of the implementation guide. Provides a background as to what this is all about. Talks about all the kind of information that we would include there. It talks about why we are doing it, the various the domains. The scope of this guide is broad. It covers a lot of different things. It really is a sort of an umbrella IG for all of the work that we've been doing at PACIO. So it interacts with the Impact Act. There's a guide here of sort of what are the main several pages that are here and how you can read those and get what you need out of it. And then there's a whole lot of packages that it's included here. This is generated by IG Publisher, but there's a whole bunch of stuff here that includes and there's descriptions of what each of these packages are. Because it is such a broadly based implementation guide, it includes a lot of different things, as well as the scope as well. So there are lots of stuff here. And excuse me. And then there's the table of contents, which has all of the various different aspects to it, and as well as a number of the artifacts, and there's a lot of them, a lot of examples. And then the formal specification, defining system roles, data sources, data consumers, and servers. Sources are, systems that originate this information. Data consumers are things that are retrieving and receiving those, and then the servers are storing it and providing that information. We talk about claiming conformance and what you need to do to conform to this IG, and then the must support. What are the must support features? Must support indicates what does software need to support, and so from the data source and the data consumer aspect. So. Then we also have use cases, personas, and scenarios. So, talking about, the personas like the intake staff, the care team, medical records team. What are they? Who are they, and what do they do? The scenarios, a transition from a skilled nursing facility to a home health agency, and from hospital to home health agency. And then some high level use case examples, such as the intake team. As a member of the intake team, I need a referral sent to my desired system electronically. As an intake team member, I need a consolidated record. As a member of the care team, I need clinical information captured by the previous provider. I need the specific information that concerns my clinical discipline. And then the medical records team, as the medical records team, I need the ability to compare quality measures captured at previous settings to quality measures captured by the care team, and see if there's any significant disparities. So these are all kinds of things where the transitions of care can really help out. Um, then general guidance. Excuse me. There's purpose of defining transitions of care data elements, why we're doing this. And, there's all kinds of different good reasons for doing it, such as comprehensive discharge planning, effective communication between providers, medication reconciliation, patient and caregiver education, follow-up care coordination, use of transitional care models, addressing social determinants of health, use of technology and telehealth, and monitoring and quality improvement. And this is the son of an updated version of the transitions of care document structure, where before we had a number of things that were sort of other that now have been replaced with more specific things. We've also added behavioral health. I'll blow this up so you can see it a little bit better. So we have this column that is new as well, and some of these other things have been identified as things that are covered elsewhere in FHIR, like dental and demographics, transportation, race, ethnicity, and so forth. And so this is really kind of what packages it all together. There's 16 different sections of this, and it kind of packages it all together to be part of that. And then we have, sort of narrative descriptions of all of these things as well. Next, into the discipline specific area. So we're, why we're selecting these data elements. We're trying to standardize data for continuity of care. We're trying to improve care coordination. We want to comply with interoperability mandates. We want to facilitate patient-centered care. We want to reduce readmissions and adverse events. And this, we talk a little bit about what we have done, which, we divided into several subgroups and got their feedback on what data elements were really important. And then, here is kind of an exhaustive list of all of the various different care elements that we decided to include, and the various different folks, the disciplines, as to whether they thought it was important or not, yes or no, and then starting with the most prevalent ones, and then going all the way down to single yes votes. So by the groups. So there's roughly, I think, there's several hundred of these here. So that lists all those items. We talk about the underlying technologies, FHIR overview and FHIR data types, and which helps folks be able to read this document. What do they need to learn about in order to get this to understand what's in the resources. And then we talk about security, privacy, and consent as well. This is pretty boilerplate, similar to what we've done with other implementation guides. Next, we have the artifacts. The capability statements indicates what the server can do. So there's talks about how you can search for all the various different types of resources here. And so that's and what what must be included, what can be complete, and what can be implemented. And then we also have our profile resources. So our resource profiles, we only have one, which is the transitions of care and composition, which is that sort of diagram I showed you. This is what it looks like in FHIR. Well, the big part of this is all the sections and slices. So there's, the advanced directives, the allergies, the behavioral health, functional status, and each one of these has, what type of data you can include in this. So that's there. We also have an extension for capturing the reason for visit, reason for referral. So this can provide the reason, but then also refer to what was the underlying information that came to, drove that conclusion. Um, we have a number of terminology data sets, for the data element library, some of the link codes and things like that. And then some of the answer lists, again, listed here, and then the transitions of care terms included, the answer list value set again. So, so a lot of this stuff is, we've talked about before, in our various other use cases. And then lots and lots of examples. So as this is a pretty broad implementation guide, so there's lots and lots of things here. We've got allergy lists, many diagnoses, discharge assessments. We've got lots of practitioners, lots of organizations, lots of locations, medication requests, medication statements, medication lists, and so forth. So this is all they all come together, packaged together as part of this overall transitions of care example. And then we have, again, the various search parameters that you can use on the bundle. And then there's various ways you can download this. You can download the full specification. You can just download the JSON definitions and examples, for this is more interesting for the technical folks. That's automatically generated by the AG publisher. So that's kind of the overview of the implementation guide. Any questions or thoughts, concerns?
So Dave, you are showing on your local version, right? Because what I send the link is I don't have. What do you have? It's
Yeah,
not
this is the local version. The
okay.
latest
Okay.
one
Yeah.
has not been posted yet. So, but this is the
Okay.
latest. But it will be posted very soon. Any other questions?
Dave, can this data set be shared? And can we publicly hand out the link?
Yeah, absolutely. Yeah.
Yeah.
So the eventual, this is my local file, but let's see, you can, if you go to, I go to this here, which lists all the various different implementation guides, and then transitions of care is here. So this would be the link. So this is not quite up to date. So there's some things like in the general guidance here, the behavioral health is still empty. But once we, push that what I showed you in here, then it should all be there. So, but this is the link that you should use. So I'll put that in the chat.
Great, thank you.
Well, actually, that's for the guidance. Let me go back to the home page there. There we go. That's the second one is the link you want.
Great, thank you.
Cool. Yeah. Any other questions? All right. Like a motion to approve.
I second.
Do I have a second? I'm sorry. Did I hear a second?
I will second.
Who is the
Yolanda.
Yeah, and who is the one who moved
Lorraine.
Lorraine, thank you. Sorry. It broke up on me. So great. Any further discussion? Anyone wish to abstain? Anyone opposed? All right, we have been approved. It's approved unanimously. Thank you very much. I'll hand it back to Yolanda.
Great. Thank you. Thank you, Dave and James, Terry as well. So next on our agenda that we have a discussion for the PACIO USCDI V6 draft comments, and I will pass over to James.
Great, thanks, Yolanda. Just give me a second to pull up slides. Be on our one. Apologize for the delay. Okay, everybody can see the slides okay?
Yes.
We've been going through these for a little while, and I appreciate everybody's patience with the process. We're going to run through and talk about some of the comments. We've broken them up into some groups, but the hope was to cover kind of three different topics today, or two of the three topics we need to get through today. And we'll probably save one for next week. The notes here are just we've kind of broken out the comments into different groupings, being the first one is those with minor changes or no changes at all. These comments are basically carry forward from what we put in towards the end of last year for the V6 process. Now that we've seen the draft V6, what ASTP is intending to put forward, we're resubmitting and confirming, the things that they have put into the draft and continuing to advocate for similar things in some of the comments, while some of the other ones. So that's the 8 out of 6 for that second bullet. And then there are 4 comments we're carrying forward and 2 additional new comments that we have kind of grouped separately that require a little bit more discussion. Before we get to that, though, I'd like to kind of cover what the USCDI levels are and how we're handling that currently, and then have a quick conversation about how the PACIO community as a whole would like to move forward in advocating for level changes. So the kind of left side is describing what's been going on up to this point. The right side is from ASTP and how they handle the levels, the criteria for those. But as noted, or sorry, not as noted, the first item is just, reiterating that last week we had some conversation, and there was a push for really just going with moving from one level to the next and not skipping levels. So going from level 0 to level 1, or if you're at level 1, level 2. And then after level 2, there is this kind of unwritten criteria that takes it from level 2 into USCDI. The second bullet is where I was saying, just reiterating that the comments that we have already been submitted once for USCDI V6. And then the next one is noting that, based on what we've seen and what we've been experiencing recently, the minor team that's putting together these comments is really leaning towards leaning into including these criteria as the major items when we put comments forward. So we do have a good, strong foundation for advocating what level any of the data elements should be at. Some other of the folks that are regular comment submitters are starting to move into that paradigm, and I think it's a very appropriate paradigm. So we're planning to start doing that after this commenting cycle. So as we go into the USCDI V7, it's the plan. But we still have to get through this final submission for USCDI V6. So we are seeking everyone's input on how to proceed, basically on the linear progression of level 0 to level 1, level 1 to 2, or keeping the comments the way they are, basically. So we just went through and we grabbed the data elements out of our sets of comments. We have 14 comments now. These are all the ones that are actually advocating for level changes versus removal or new vocabulary additions and things like that. So the three in the middle, the nutrition order, which is a new data element, the nutrition status, and the patient communication status, are the three that don't follow that linear progression. The other four that are on the table on the right go from one level to the immediate next. I did want to note that out of those three items that kind of skip levels, nutrition order has gone directly from being a new item into the draft of USCDI. So I don't think we're going to change our approach to that one, or I would recommend that we don't. So really, the only two data elements that we're talking about currently are the nutrition status going from level 0 to level 2, and the patient communication status going from level 0 to level all the way into USCDI was the recommendation. Does anybody have any questions about any of that before we jump down to the question at the bottom of the slide? No. Okay. So I'm gonna put the question out there. The question that I think is relevant at the moment is how PACIO should move, PACIO, the community as a whole, should move forward with our submission for these comments, knowing that we've submitted them once already, but they will change. This will be the last time they're submitted in their current form before we go into kind of that new paradigm for USCDI V7. So the question is, should PACIO move forward with the stepwise USCDI data element progression for this comment period, which affects the nutrition status and the patient communication status, basically moving both of those down from moving those to move from level 0 to level 1. So I'd like to get your feedback now before anything else. Michelle.
Hey, James, I'm curious, do you have any insight into how nutrition order went from new element into current V6 final draft? I didn't realize that when I was looking at things before, and that to me seems to open a door into maybe element maturity even as it kicks off.
Right. I don't. The only thing I can say is I think that is overall a fairly mature data element in the general sense of application, integration into EHRs. So it's, when we start considering how to move forward in the future, if we're looking at the criteria, that's really the critical part of not necessarily moving through each step. So I have to assume that it's a fairly mature element, and ASTP felt comfortable with the amount of evidence provided between our comment and others.
Thank you.
Hey, James, this is Lorraine. I'm not going to derail anything here, but I did go back and look at some of the stuff on the website of USCDI and ASTP. And it seems that there have been times before, and then you could put forth something, say if it's in level 0 to jump to level 2, that it doesn't have to be sequential, that it is really the criteria, right? And then you could go from level 1 and to put it into a version. So, I mean, it makes sense that it's set up a certain way, and that, probably that's the way things usually develop and then get more traction. And so it needs more of the criteria, but I think that it's not this way or no way. So I just want to put it out there that it makes sense. It's set up that way, but it does say you don't have to follow that way, right? You could have something level 0 and go to level 2 or level 1 and want to put it in a version or something, as long as it meets the criteria that, is required in each level or version, maturity level.
Thanks, Lorraine. Joanne.
Yeah, thank you. I'm as far as patient communication status, that's something that we have discussed as being woefully lacking, that we don't have that at all in USCDI at this point. So I would not, if I'm following what you're proposing, I would not want to go through the steps. I think that it would warrant, it seems most appropriate to really push to get that into USCDI as soon as possible. There's nothing to stop them from moving it just from one level to the next. But if as a group, we continue to advocate to get that in there as soon as possible. We've explained that it is a concern and a safety issue, and that's something that from a patient function and safety, it's needed as soon as possible.
Thank you. Yeah, I know there's been a lot of discussion around the patient communication status, and so I appreciate the reiteration that it's really a critical data element and should be included soon. Thank you. Anyone else have any thoughts? I know Maria is one of the ones that was very passionate about moving between steps, and I know she wasn't able to be here today. So I don't want it to sound like nobody has that mindset that some parts of the PACIO community do. So I don't want it to sound like everybody's in complete concurrence as we move forward. But Michelle.
I think I want to underscore what I heard Lorraine saying, and with the ability to meet criteria, should not, if we can accelerate a data element to get through and meet the majority of or all of the criteria, it seems to me that that data element should be promoted probably faster than a stepwise cycle review. Otherwise, we are waiting truly years for it to make it through a stepwise approach. That being said, if it doesn't meet all of the criteria, but it meets, 3 out of the 4, 2 out of the 4, whatever the case might be, we should recommend promoting based on meeting criteria. But not hold back because we just introduced something or we just made it to level 1. So we should wait for next year for level 2.
Yeah, I completely understand. Thank you, Michelle. So I think at this point, I'm sorry, Yolanda, did you want us to vote on a path forward with the stepwise progression or progressing as the comments are?
I think we should, because that's kind of affects how we want to handle the rest of the comments, right? If we approve the level strategy as it shows now, and we can just discuss the rest of the comments. If the community all agree we should follow the stepwise one by one, and then we need to modify our comments. That's my sense. We should do a vote.
Okay. I guess I will.
So do I hear a motion?
Yeah. I motion that we progress with the comments as they currently are for this comment cycle.
Is there a second?
Just to clarify, currently R is to not change.
To include skipping steps. Yeah.
So the motion is to allow skipping steps, or the motion is to not allow skipping steps?
To allow skipping steps.
Okay. And if
Sorry,
we're allowing,
did you just want me to phrase it that way?
And I think that's
okay.
For me.
Well, I think it's skipping steps in accordance with the, with the requirements. So.
Right. So if you're allowing skipping steps, then I will second.
Do I have a second? Do I have a second?
Seconded.
Okay, great. Any discussion? Any further discussion? All right, not hearing any, we'll proceed. Anyone abstaining? Anyone opposed? The motion passes unanimously. That's 1300.
Thanks,
Thank you.
Dave. Now we'll move into the next part of the USCDI comments. I'll just highlight real quick. These little DEs and other bracket sections are just abbreviations, basically, to make this present well on a slide. The full comments are available on Confluence page. I don't have that link handy, but we can share that out in a second. But it's been posted to Confluence for folks to review. We did want to get through at least a portion of these today, and the ones that have no substantial change are the ones we were going to focus on. So we're going to have 8 out of our 14 comments. Just real briefly go through and review them, and then we'll take a vote to approve those comments at least, so we can move forward with that. So I'll go through each data element kind of quickly and just remind folks what our request was from last time. For disability status, we've requested that this disability status be removed from the health status data element class and instead be included as a disability as a patient demographic information element or data element. So that has largely stayed the same, and we're carrying that forward as is. The next two, the functional status and mental cognitive status data elements, we've recommended basically a vocabulary addition to include the ASHA FCM, the functional communication measures. So a vocabulary addition for those two data elements. For the next comment is the functional status, health concerns, and mental and cognitive status data element. Also add the vocabulary for the ICF. For nutrition status, we're continuing forward with the recommendation that that data element move from level 0 to level 2. And for device used, advance from level 2 into directly into USCDI v6. Does anybody have any questions about those before we move on? Okay, keep pressing on then. And the last 3 of the data elements that have been carried forward, nutrition order. This was the new submission that has been accepted as part of USCDI v6, or we recommended that it go into USCDI and also as a level 2 data element. And ASTP has confirmed that they confirmed that by including it in the draft v6. So this one has already been included into USCDI. The second data element here, the portable medical orders for life-sustaining treatment, excuse me. The recommendation is to remove this data element. Part of the justification is that the portable medical order data element is also in place now, so this is unnecessary at this point. This has been a recommendation for a while though. And then the last recommendation is that drug class data element have a vocabulary added to include med-RT. So I think that is all of the ones that don't have any substantial change. I will double check. I'm having hesitation on this one that is a new data element, and I will double check it. But sorry, I'll go back to this. Does anybody have any questions or comments about these data elements? Okay. So I think at this point, we'll just take a vote to see if the community is comfortable with moving these forward and having them approved for final comment. I will make that motion and say, I motion that the comments with no substantial change be approved by the PACIO community for submission to USCDI.
Motion has been made. Is there a second?
I'll second.
Thank you, Joanne. Or Michelle.
Michelle.
And any further discussion? Not hearing anything. We'll proceed with the vote. Anyone want to abstain? Anyone opposed? The motion passes unanimously, 11-0-0. Thank you.
Yolanda, I can pass it back to you, or we can go through some of the other comments that had changes or new additions if you'd like. I think we have some time. Or
yes, yeah, go ahead. And I think that's still under discussion, but we want to give the community an idea of the rest of the comments. We are still seeking feedback.
Okay. So these will not be necessarily for vote, but just for understanding and feedback as we move forward. The advanced directive data element, we've received feedback from, I want to say Maria, who's part of one of the ADI leads or advanced directive leads, that we should withdraw our comment towards the advanced directive data element because there's not a sufficiently mature standard to point to for part of our justification for submitting that. So that is going to be no longer. We submitted it in the initial version of the comments for USCDI v6, and for the second round of commenting on that same version, we will not submit a comment for this one. Any questions or comments about that? Okay. The purpose of capture. This is part of the, I believe, Providence data class. The prior comments that we had for this were to put forward either the purpose of capture or rationale. We've changed it to be just focused on promoting the purpose of capture to move to level 1. And we're no longer referencing the rationale nor suggesting it be removed, just kind of leaving it there in level 0. The principal reason behind this was aligning with CMS and the HIT work group, who are submitting comments for advancing
James, I think we lost your sound.
So the primary rationales there, just signifying the importance of purpose of capture and the understanding why and how different data elements were captured, to help understand and make sure that those data elements are taken into the right context when used for decision making. Does anybody have any comments or thoughts about that they'd like to share now? Okay. Forward into patient communication status data element. This one, the current recommendation is to move forward with the patient communication status as is, moving that from level 0 directly into USCDI v6. This is still under conversation and feedback and iteration. But this has been changed significantly from our prior comment, which was to move this data element forward, but to rename it patient communication and move it into the patient demographic data class. So it's fairly significant change in the comment, since we are no longer advocating for it to kind of morph from one kind of data element being a status into a personal characteristic. I think it was the personal function and engagement community felt very strongly that the patient communication status is a critical data element that really does need to be captured. So any questions or comments about this data element? Okay. The last one is the portable medical order. So I'll actually start with the previous comment. The previous comment was advancing the portable medical orders to USCDI v6, but also rename it to portable medical order, singular, so that it is clear about what each data element represents, that it's not a collection of orders, it's just a singular. So that comment has been accepted, and the portable medical order, as described previously, has been accepted into USCDI v6 as the draft. We've gotten new input that is basically helping to express that the portable medical orders, portable medical order as is, doesn't have a good foundation in existing standards. So trying to help recraft the definition. So the new comment includes and update the description of what the data element represents, so that it can be more accurately used as a way to capture unstructured and structured medical order information, portable medical order information. The reason being, there's a lot of legacy information out there that's not structured, and it was felt very strongly that we need to be able to handle that unstructured data and adequately capture it and pass it along into other settings where necessary. That's one of the major emphasis of the portable part of the medical. Does anybody have any questions or feedback on that?
I just want to add, so the MITRE team will share the full document for the data elements James just discussed, and make it available on conference page before we discuss and vote. So just this is kind of just a preview for the change we are thinking we should put in, but definitely we still have time to collect the feedback from the community.
The last two, and each one gets its own slide, are new data elements based on requests that we've had to get feedback from the PACIO community, from CMS and the HIT work group. The criticality data element is part of the allergy and intolerance data class. There was questions whether the PACIO community would support, and the input that we've received was yes, criticality is a very important data element. So we are recommending, we're going to submit a new comment this cycle to indicate that we believe it should be moved from level 2 into final USCDI v6. In essence, that block of text rationale indicates that criticality is one of the major data elements that goes along with clinical manifestation, aka reaction, along with the allergy or intolerance data element, or allergy or intolerance agent, this line right here. Along with those, the agent and the reaction, criticality is kind of the other major data element, so that clinicians will know how to engage with known allergy or intolerance and know what the future reactions might be. So that's the underlying rationale, is to be able to plan for future reactions if those agents are engaged with, and to plan other alternative treatments or interventions as necessary. We do have recommendations of the appropriate link codes to use, so we're also advocating for the appropriate vocabulary. Does anybody have any questions or feedback on this item? All right. And I should have said this before, as always, if I move along and you have questions or comments on the earlier one, just let me know. I try not to leave too much time, but just enough to let people speak up. But if I go too fast, please let me know and we'll go back. All right. And our last comment that we are planning for right now, the drug class allergy intolerance data element, also under the allergy and intolerance data class. During the review of the criticality, it was also noted that it would be appropriate to add another vocabulary to the drug class allergy intolerance data element. So we've worked up the rationale to help support that, basically noting that this data element would be appropriate to also include, excuse me, the med-RT that has, as part of it, RX norm, mesh, and SNOMED CT, which were the existing vocabularies within or that support that data element, but adding MRT makes it a little bit more robust. So, does anybody have any comments or feedback related to that data element? All right. With that, I will note that we did send out a request for some other comments that we received from CMS and the HIT work group related to medication. We shared those with our transitions of care community, since a lot of the medication, all of those data elements were medication administration related, and that was really the justification that currently is being put forward, leans heavily on transitions of care. So we were seeking their input specifically. I believe we sent out those same comments earlier for feedback, but we haven't gotten any others. We haven't gotten any from the transitions of care community as of yet, but I believe I put the deadline for feedback shortly before the next HIT work meeting. So there's a little bit of time still on that request that we have out there. That's all I have. Does anybody have any other questions or comments regarding the US CDI comments from the PACIO community? All right, turn it back to you, Yolanda. Thanks, everybody.
All right. Thank you very much. So thank you very much, James. And I think we plow through all the items on the agenda. Any walk-on topics from anybody? Hearing none. And I think I really appreciate everyone's contribution and your inputs. And this is a very productive meeting. And we have done a lot. And I think this great community, and we are expecting more from the community, and we are also working toward our the Dave's side and moving to the right direction. And thank you all very much, and wish you enjoy the rest of your day. And we will talk to you next time. Thank you.
Thank you, everybody. We couldn't do it without you.
Yep.